histotripsy. But when I was speaking with him and preparing for the talk, he had mentioned he really thinks it's important for patients to understand not just histotripsy by itself, but all of the different treatments, liver-directed treatments that are available, so patients can really make wise, informed decisions, and be part of their care. So I really want to thank him on behalf of Colon Town for being here tonight. And I'm going to turn it over to him in just a second. I want to make sure everyone knows how it's going to work. So Dr. Rocca is going to speak to us, present to us, give us his wisdom. And if you have questions for him at the end, there will be a time for questions. So please use the chat feature here in Zoom. You just click chat and add your question to the chat. So the questions will be held to the end of the presentation. And then at the end, when we have time for Q&A, I will read the questions to him and he will answer those questions. So without further ado, I'm going to turn it over to Dr. Rocca. Again, thank you for being here. We're so excited to learn from you.
Thank you so much, Betsy, for inviting me to speak. And I hope that I can help you figure out different treatment options. I think that, here at Cornell, we are a division of surgeons that do liver surgery, liver transplantation, histotripsy, and we work hand in hand with our oncologists and interventional radiologists with ablation, our radiation oncologists with radiation. And we have once a week, we have a meeting, which is called a multidisciplinary tumor board, where we bring our cases and we have the input of absolute every physician that is involved in the care of colorectal cancer. And I think it's an amazing meeting because that really tries to bring the best treatment option for each individual patient. And this is the purpose of this talk today. I think that it's important to try to clarify, so I have no conflicts, but I just wanted to clarify the purpose of the talk. I think that many of you may know about one or two options that were presented to you, but not all of the options. So maybe you feel you're being boxed in the care you're getting, or where you went to get your first consultation about the treatment of your situation. So it's to, the main purpose of this talk is to educate about all the different treatment options. But then, many of you also may know about all the different options and may be really confused about what is the best option for you, or if you want to know more about the benefits and the risks of each of the treatments or combination of treatments. And finally, I hope I can just, in the different situations I'm going to be presenting, I hope that you can relate to those situations and you can decide what of these options may be working best for you. So the outline of the presentation has multiple components, but first we're going to do a quick overview of the treatments that are available for colorectal liver metastases. This is only metastasis to the liver, the main focus. Then we're going to be discussing what is the gold standard in the treatment of colorectal liver metastases, which today is a combination of systemic treatments, which is mainly chemotherapy and targeted therapies and surgery, right? That's what we consider the gold standard. From there, we have a lot of data about how that works. And from there, we can move on to other combination of therapies when surgery is not a good option. For that, we need to discuss what is resectable disease, that is disease that can be treated with surgery, versus unresectable disease, okay? And then we are also going to be discussing the role of ablation. You probably heard about ablation. There are different types of ablation, but ablation can be done with microwaves or radiofrequency. And this can be used with surgery or can be used for resectable disease, but also can be used on unresectable disease. Then we're going to go over the role of other local regional therapies, okay, and the different combinations of them. We're going to discuss the role of liver transplantation. It's a very strict criteria for liver transplantation, but we're going to go over that. And finally, we are going to discuss how histotripsy can contribute to this multimodal management of colorectal liver metastases. It's a new technology. It's quite promising in many aspects, and everybody's embracing it. Now, we don't have too much data to really put it against the other treatments. And so it's something that, it's important to disclose that, it is promising, it's exciting. I do it quite often, and it's just that sometimes it's hard to offer something that we don't have a complete proof that it works in the long term. So that's why I leave it for the end. Okay. So let's go with the treatments available for colorectal liver metastasis, starting with what we call the systemic therapies, which is a mix of different regimens of chemotherapy. All of these sound familiar to you: Folsox, FOLFIRI, Capox, and different targeted therapies like Avastin, cetuximab, panitumumab, pembro, and all these regimens can be combined depending the different type of mutations that the tumors may have, like the MSI status, the RAS mutations, the BRAF mutations that are of worse prognosis, but now there are more trials and treatments for BRAF mutations, HER2 mutations as well. And the systemic therapies are the backbone of colorectal liver metastases. In the past, we used to probably use it only in some situations. Now it's pretty much on every situation. Now, for locoregional therapies, I always include surgery as a locoregional therapy, because at the end of the day, when we do liver surgery, even liver transplantation, we are treating the disease in one spot, in one region. Okay, so it's a locoregional therapy. So it probably is better to divide it in those locoregional therapies that require an operation, require surgery, like resection, which is surgery. With or without ablation, we do ablation at the time of an operation, an open operation, a robotic operation. We can do ablation or laparoscopic operation. We can do ablation together with resection. We're going to also touch on the role of the hepatic arterial infusion pump and liver transplantation. All these require operations, okay? And then some therapies that do not require operation is also ablation, which can be done percutaneously with the interventional radiologist. Y90 radioembolization, which is an injection of material with radioactive activity into the liver, radiation, external radiation, and histotripsy. So first, let's talk about the management of colorectal liver metastasis. In the last 20 years has improved significantly. The survival of patients who have colorectal liver metastasis improved for 3 reasons, mainly because we have much better chemotherapy and immunotherapies and different targeted therapies. We have been a lot more aggressive with the surgery that we perform for colorectal liver metastasis, and we also have better locoregional treatments, like we're going to go in a little bit. But if you look at in the last 20 years, the number of operations we're doing for colorectal liver metastasis has increased significantly. And when you divide those patients that made it to surgery versus those that could not have surgery, that's a striking difference in the survival. So that's why today the being able to say that we have resectable disease is really very important, because impacts in the prognosis, impacts in the survival. And most of the survival, we're going to try to put it at the 5-year mark, which is, I think, is what most of the papers usually are able to measure or compare survival of different combinations of techniques. So let's try to define resectable disease first, okay? So resectable disease is that the tumor in the liver or the tumors in the liver can be removed or treated with liver surgery, okay? And the goal of the resectable disease, the goal is to get to a condition of what we call NED, which is no evidence of disease, because this is associated with the longest survival, right? If we can bring you NED, even knowing that the tumor may come back later, each time we bring you NED, we're giving you the best chance of having the longest survival. Now, resectable disease may require systemic therapy before surgery, more and more, okay? In the past, we used to discuss that some situations were benefited first with surgery and then chemotherapy, but now the data is, moving more towards trying to do systemic therapy and then surgery in the liver, mostly when you have a higher number of tumors in the liver. Sometimes they require more than one operation. We will call stage hepatectomy or stage operations, or a combination of an operation with a local regional treatment afterwards in order to get you to the NED status. And one of the conditions is that the patient has to be able to go through an invasive procedure and through surgery. Now, on the other hand, unresectable disease is the opposite of this, of course. The tumors cannot be removed with or treated with liver surgery, or we can, but by removing them, we are not being able to bring you NED. Okay, we cannot get rid of all the disease. And this is usually conditioned by the number, the size, and the location of the liver tumors. Sometimes you have small tumors that are in a poor location inside the liver that require a major operation of the liver. So that's when other techniques may really be able to bring you closer to resectable. Sometimes the condition of the liver, the chemotherapy can be toxic, can give you fatty liver, can give you fibrosis, can give you some scarring on the liver. So the liver may not be able to tolerate a big operation. Sometimes when we do systemic therapy, it's a good test of time to kind of understand the biology of that tumor. And if the tumor progresses on chemotherapy, it's telling us that doing surgery on that liver tumor is probably not going to help too much. So that could be a reason for being unresectable. Technically, we can do the operation, but the biology of the tumor is telling us that it's not going to help the operation. Or sometimes you have disease outside the liver that dictates the survival more than the disease in the liver. You can have disease outside the liver. For example, in the lungs, the disease in the lungs is quite indolent and easy to manage. The disease in the peritoneum is difficult to make it respond to chemotherapy. Bone disease, etc. So there are different situations which requires really a multidisciplinary decision about what is the best treatment option. Just want to highlight this because, again, in the past and not long ago, we were discussing if preoperative systemic therapy before liver surgery was a good thing to do. And yeah, maybe for a single lesion that came years after removing the colon, a slow progression, maybe you can argue that you could do an upfront resection and then do chemotherapy later. But more and more data is coming out that the use of systemic therapy, mostly when you have a bigger number of lesions, is really important in making the disease more controllable for surgery, and that improves the recurrence after the surgery. So this is a nice study. It's about 1,000 patients that were matched between those that had only chemotherapy versus those that have chemotherapy and surgery, but they were matched based on the size of the tumors and the number of the tumors, and there are different scores that are standard, the CRS score, the TBS score, the GAME score. These are different scoring systems that we have to assess risk of liver metastasis and the risk of recurrence. And clearly those that receive chemo before the surgery did better in the overall survival, and did better if you look at the recurrence-free survival. For the first 2-3 years, they were kind of, the two groups were about the same, but then after 3 years they start spreading again. And those that didn't receive chemo before surgery had a less recurrence-free survival than those that received chemo. So I think this is one of the many studies that now are showing the benefit of having systemic treatment before surgery. Now, a few other concepts of surgery in colorectal liver metastasis. First is we want to resect the tumor with clear margins. That means that we want to cut the liver where there is no tumor, right? But we also want to leave enough liver volume. Clear margins can be, as for colorectal liver metastasis, can be as little as 1 millimeter. That's enough. Even when a tumor is sitting on a blood vessel near the liver, if we peel it off, that's enough too. So it's not that we need to do a lot of surgery around the tumor. And this is important. The type of surgeries that we usually do, any liver surgery, we can have what we call the wedge resection, where we take a little piece where the tumor is sitting, or we can start taking segments of the liver. The liver has 8 segments, and we can take, like, for example, this would be like 25% of the liver. This would be almost a 35-40% of the liver. The left hepatectomy, the extended left hepatectomy is almost a 70% of the liver. Then we have different sections of the liver. So typically for colorectal liver metastasis, we try to avoid doing anatomical hepatectomies, and we try to go around the lesion. Okay, so the type of surgeries that we usually do for colorectal liver metastasis, here in the first column, the type A, is what we call the parenchyma sparing liver surgery. That means that, knowing that we need to, have at least 1 millimeter of margin, we go around the lesion as many times as we can. Not always we can. Sometimes the lesions are too big, like you can see in the B column. And if the lesions are too big, either we are forced to cut the right side of the liver, for example, and remove maybe 60% of the liver. Or sometimes if we feel that the remnant liver is not enough, we might need to do some intermediate steps, like what we call portal vein embolization, to let to deprive of blood flow to the side of liver we're going to remove, and let the other side grow before doing the operation. Sometimes we do the 2-stage liver surgery when we have multiple lesions on both sides. We first do an operation on one side, and we remove, for example, here, these 2 small lesions on the left side. We remove them, we wait for the liver to grow, and then maybe 6 weeks or 8 weeks later, we can go back and remove the entire right side with all the lesions. But these are goals of surgeries with the goal of bringing the patient NED, without evidence of disease. And this is the ALPS procedure, which is, again, is another 2-stage procedure where we cut the liver halfway. We don't cut it all, and we remove the tumors, and that will accelerate the growth of the liver. Instead of in 6 to 8 weeks, we can go back in 2 weeks and remove the other side of the liver. Again, as you can see, the complexity of these operations increases when you have a bigger size of tumor or a bigger number of tumors, or both sides of the liver. But these are all techniques that we use to be able to bring the disease to zero, at least with the method that we have today to see disease, which is CT scan and MRI or PET scan. Now, why it's important to save as much liver as we can is because when the 70% of the tumors that we remove, when you have multiple tumors, 70% end up coming back at some point, right? And if our goal is to prolong the survival, okay, as much as we can, we need to have enough liver to keep treating that liver, okay? And we sometimes do a second surgery in the long term, like 2 years later, or even a third operation um, um, to take care of new lesions that are coming back after a while. But then also it's important to understand that ablation has a big role here, because those patients that could have, when the tumor comes back, they could have a second operation or an ablation to treat the tumor. They have a better survival in the long term. Those are the ones that we managed to bring them to the 5-year mark. Okay, and I think that's important to understand that, you know, sometimes, you know, patients that have resectable disease have the best prognosis for a 5-year survival, but many times may require more than one operation, more than one procedure, while still receiving systemic therapy. Okay, this is how we get you there. Okay. This is just a study to show that, you know, the difference between doing a major hepatectomy, like cutting half of the liver, versus doing a parenchymal sparing hepatectomy and ablation to take care of many lesions. And this is an important study that showed that when you compare those strategies, they have the same survival, and the patients that have parenchymal sparing hepatectomy and ablation have less complications than those that have a major hepatectomy, which is important. And this is an important number here. Back in 2014, only 31% of the cases were being done with parenchymal sparing surgery and ablation, and that rose to almost 50% in 2022, which is an important trend. We really use ablation a lot when it comes to colorectal liver metastases. And this is a study that came out this week, actually, another multi-center study that compares the role of ablation or surgery when you are talking about tumors that are 3 centimeters or less in size. And they have the same outcome, okay? It's not inferior to do ablation or resection versus resection. Resection is the gold standard, but now ablation up to tumors of 3 centimeters is equivalent. And this is really important because sometimes if we do an operation, we clear your tumor, and a year or two later, you have new tumor coming back, you might be able to get away with ablation without surgery, okay? Or if I go and do an operation and to treat 3 tumors, and I can safely remove 2, but the third one is in a tough spot, or I may require to remove more liver, I can do an ablation of that tumor, and that is equivalent. Okay, as long as the tumors are 3 centimeters or less. This is another important thing, is as we have a higher number of tumors in the liver, we have less chances of surviving in the long term, or a higher size of tumors, okay? This is the liver met survey registry. This is the largest registry in colorectal liver metastases. And, you know, I just wanted to show you that these are the things that we always consider for putting someone in the category of being resectable or being unresectable. If sometimes technically we can remove all these lesions, but they tend to come back, okay? So resectability is not only a matter of a technical surgery, okay? It's also had to do with the tumor biology and the number, the size, but also how long it takes for that tumor to come back, okay? Sometimes when we do operations, and we have what we call the very early recurrence after, you know, we do an operation, we get the patient NED, and then in about 3 months, we have new tumor that is telling us that the biology of that tumor is aggressive, and that usually is associated with the number of lesions that we have, or if there's any extrahepatic disease, or if there's any mutation. And you know, it's important to sometimes the surgery the outcome after the surgery will tell us a bit more about the biology of that tumor, and that will guide our decisions about what to do next. So in summary, liver surgery for resectable scenarios, I think it's always important to understand that surgery always has risk. Liver surgery is always complex, even if we do it small, as small as we can. But it offers really good long-term outcomes. 50% can achieve long-term survival after a successful resection. Always, in my opinion, combined with systemic therapy. And it's also important to understand that many of these tumors are going to come back in 5 years, 60 to 70%, and that's why we need to keep treating it as aggressive as we can. Now, what happens for those that we consider that we cannot resect, that it is beyond all these different scenarios that I just showed you, where we can do an operation or an ablation? Well, first, I think if you do systemic therapy alone, chemotherapy, and now with targeted therapies, the survival at 5 years is about 20%. But still, it's important to understand that this is the backbone of the multimodal treatments, okay? And over that, that's backbone of systemic therapy, we can add the benefit of other local regional therapies that can improve the survival, okay? And those other local regional treatments can be ablations, that a non-surgical ablation, percutaneous ablation, Y90 radioembolization, and external radiation. So a brief description of each of these. Ablation can be done with radiofrequency or microwave. We usually put a needle inside the tumor in the liver, and pretty much we burn the tissue, okay? So that pretty much burns the tumor tissue and the liver tissue that is around with the margin, same thing that we would do in surgery, to make that tumor cells dead, okay? And that can increase maybe 10% more the survival at 5 years if we combine it with systemic therapy. Now, we don't have a lot of data about Y90 radioembolization at 5 years, but yes, we use it when we have tumors that are more than 3 centimeters, where ablation doesn't really do a good job, and we inject the tumor inside with radioactive particles, and the tumor slowly gets irradiated and becomes non-viable or dies. And these injections can be done very focal at the level of the tumor or in different segments. Sometimes for liver transplantation, we use it on the whole liver to keep the tumor at bay until we get to a transplant. I think it's really an important treatment, and it's always important to consider. And then we have the external radiation, or SBRT, which again, we don't have long-term data. We usually reserve for those patients that cannot receive other treatments. But yes, we do know that it's able to achieve good local control of the tumor, at least on the first 2 years, when we irradiate a tumor in the liver. So I want to bring, to the discussion also the role of the hepatic arterial infusion pump, which nowadays is not just that, it's combined also with systemic therapy, okay? But you probably heard about this, but usually for unresectable disease, when you have tumors that are at both sides of the liver and multiple tumors, is a good method to downstage the tumors, okay? To decrease the size and the number, and sometimes convert them to resectable, okay? So what it does is, because the chemotherapy is usually toxic to the entire systems, we give only some specific chemotherapy into the liver, and that first passage into the liver will make the chemotherapy concentrate in the liver only and not give toxicity to the rest of the body, okay? It does have survival benefits, because about 50% of those that receive hepatic arterial infusion pump may be able to be downstage to the point that they can be converted to surgery. Okay. When you put all together, the latest studies are, the overall 5-year survival for unresectable disease with the pump is about 50%. But then if you divide into those that responded to the pump and the systemic therapy and were able to have surgery, those had a survival of about 70% at 5 years. But then the other ones didn't respond. It's about 50-50. The other half that did not respond didn't make it to the 5 years. But again, these are not only therapies that allow you
In one day, I got
to downstage treatment, but also to be able to understand the biology of the tumor. And those tumors that respond, they have a shot at having surgery or even transplantation. And those tumors that do not respond, or at least we try a very aggressive therapy. And if they did not respond, the biology really was declared. All right. So now, liver transplantation. Liver transplantation is the most radical treatment for liver disease from colorectal liver metastases. And that's why we call it the ultimate local original treatment. Because what we do is we take care of some cases of unresectable disease, okay? Liver transplantation should not be offered to those that have resectable disease because they have very good survival. But those have no unresectable disease, and they have a 5-year survival below 50%, below 30%. Some of them, they could benefit from having a complete removal of the liver. And by removing the entire liver, we're not only removing the tumors, but also we're removing the factors that are in that specific liver that allow the tumor to come back, okay? So that's the rationale behind it. But of course, for that, you need to be able to have a disease that is well controlled, right? So it's kind of a long pathway to get to transplant. And many times, all these different techniques that I told you that are beyond surgery, like ablation, like a radioembolization or Y90, radiation, or even the hepatic arterial infusion pump, are methods that we use to keep the disease at bay so we can make it to transplant. We use a lot of time as a test of time to tell us that the biology of that tumor is manageable to the point that we can do a liver transplant and not have an immediate recurrence, okay? So this is the latest study that we have in transplantation. We have some data from United States. We have data from Norway, which were the pioneers on this more than 10 years ago. But this is the study that came out last year in 2024. And it's a multi-center study in different countries of Europe. And they show that if you transplant patients with unresectable liver metastasis under central criteria of the stability of disease, and the liver has to be restricted only to the liver. The disease has to be restricted only to the liver. You cannot have peritoneal disease, you cannot have bone disease, you cannot have lung disease. So with that criteria, when they look at the intention to treat, this is all the patients that were recruited into the trial. The 5-year survival was 56% for those that receive a liver transplant versus 12% for those that only receive chemotherapy. Now, when you start tweaking a little bit the criteria and make it stricter, okay, then the 5-year survival, that's what they call the per protocol survival. The 5-year survival went up to 73% when you did liver transplant and chemotherapy versus 9% for chemotherapy alone. So this is important because this 73%, this is beyond what we consider the survival benefit of a liver transplant. okay, which is about 60% at 5 years. Remember that liver transplant is a standard practice for many other diseases, starting with liver cirrhosis and many other diseases that are not related to cancer, or some diseases that are related to liver cancer from primary liver tumors. And they have a high standard of survival. The survival of the liver transplant at 5 years nowadays is above 80% for most of the indications. And for some cancer indications, about 70%. So it's hard to really start doing liver transplants for colorectal liver metastases if we're going to be having a 5-year survival that is below that benchmark of about 60%. Okay. Now, the other thing I wanted to show you about this data is that, as you can see on the progression-free survival per protocol, those that receive a liver transplant with the red dot, the red dotted line, so they did have recurrence. They did have a fair amount of recurrence, but by 2 years, 50% have some sort of recurrence. And we're going to talk about that. But much of that recurrence could be treated, okay? So if you can treat the recurrence after a liver transplant, you have this concept that we have here is the secondary progression-free survival. That is how you prolong the survival after treating the recurrence. So we're going to go a little bit deeper into this and talk about the recurrence patterns after a liver transplant and the difference with the liver surgery. If I do liver surgery for colorectal liver metastases, the primary site of recurrence will be typically the liver, okay? Because the liver that I did surgery on still has the conditions for new tumor is harboring microscopic tumor or new tumor to be seeded and grow back and recur, okay? When we do a liver transplant, not only we're removing the tumor, but we're removing that liver with those factors, and we're putting a different liver that may not have those factors. So the recurrence pattern after liver transplant is not in the liver, it's mostly in the lungs, okay? And as I told you before, the lung metastases are indolent, are usually, they take a long time to progress. They're not as life-threatening as a metastasis in the liver or the bones, okay, or the brain, right? So it is important to consider this when, we know that some patients have lung metastasis after liver transplant, but they can be treated with surgery. And this is an example that I want to show you. This was done last year in Chicago. I trained in Northwestern Memorial, actually, many years ago. And a young patient that received a liver transplant for colorectal liver metastasis was 80 years out from that liver transplant, without problems, except for some lung metastasis that had recurred and was stable. But they kept coming back after different treatments. So was for the first time, it was decided to do a lung transplant for metastasis in the lung 80 years later after a liver transplant. So this is way far from what we consider standard of care, but at least it's giving us a glimpse of what we could achieve by having long-term survival for unresectable colorectal liver metastases. Of course, we have to be very cautious with all this, and unfortunately, the patients that can be eligible for a liver transplant, the patient with colorectal metastasis, are about 1 or 2% of all the patients that are out there. So this is an important figure that can give you a sense, of all the patients that have colorectal cancer, half of them have colorectal liver metastases. About 30 to 50% of them have no evidence of extrahepatic disease, which means that we could consider liver transplantation. But 70% of them are technically resectable, so we should resect them. And then there's a 10% that, if we consider all the selection criteria, may be able to be considered for transplantation, but then in the end, through the pathway of transplantation, which requires a wait time, it requires treatments, it requires to go through a transplant evaluation and to receive an organ transplant from either a live donor or a deceased donor. Only 1 or 2% may be able to receive it. Okay, so this is encouraging to be able to come with liver transplant, but still it doesn't have the scale to impact everyone. Okay, this is just to show you the protocol that we have at Westchester at Weill Cornell for transplantation of colorectal liver metastases. We have a trial that is listed in the clinicaltrials.gov site. We did transplant 5 patients, but we did evaluate, this is a bit old, we did evaluate more than 35 patients. The definition of unresectable is made at the tumor board. Okay, we look at the imaging and we have surgeons, we have oncologists, we have interventional radiologists, and we come up with different strategies to decrease the tumor burden and see if there's a way to resect this patient and make them NED. If we don't find a way, then that patient, if only has disease limited to the liver, that patient may be able to go into liver transplantation. And for that, we need to have different tests of the lungs, the liver, a PET CT. We usually do 6 months of chemotherapy, and we have to make sure that the disease remains stable or responds. And then sometimes we have to remove the primary tumor. If the colon tumor was still there, we have to remove it and wait and give another treatment session. And then closer to the transplant, we typically give lobar Y90, which is this radioembolization to both sides of the liver, because at some point we need to stop the immunotherapy before the liver transplant, and we need to wait about 6 to 8 weeks for that immunotherapy to go away, and we want to have some control on the tumor with the Y90. That's why we usually give it. The problem with Y90 is quite toxic to the liver, so we have a little window there to stop the immunotherapy with the effect of the Y90 and then do the liver transplant. This is a summary of the outcomes of different scenarios for colorectal liver metastases. So starting with the easier scenario, single liver metastases, you can have a 5-year survival up to 60% with surgery and systemic chemotherapy. If you have multiple liver metastases that are resectable, you have combination of different treatments that I just told you, and you can have survival rates that go between 40 to 50% at 5 years. If you have multiple liver metastases that are unresectable, your 5-year survival can go from 10 to 20% if chemo only, up to 30% if you add ablation or chemoembolization or radiation to it. If you have an arterial infusion pump, a hepatic arterial infusion pump, your overall survival can stretch to 50% or more. It depends on if you respond to the arterial infusion pump. If you don't respond, your 5-year survival won't get to 5 years. It's going to be hard, but you might be able to respond and become eligible to either have surgery or transplant for some cases. We do consider patients that are being downstage with hepatic arterial infusion pump we do consider for transplant in some situations. And then liver transplantation, if you make it to liver transplantation, again, 1 to 2% only can make it there. You can get up to 75 to 80% of 5-year survival. So really, it doesn't have the scale, but yes, it's very promising for those that can meet the criteria. So now let's put this into the right context. I think this is a great picture to tell us what is the scale of all this. Okay, so unresectable here at the bottom, if unresectable are in the 10,000, resectable is about 10% of that and the thousands. Okay, so the resectable disease, as we define it, that we can do surgery combined with chemotherapy, maybe with ablation, the tumor comes back, we do surgery again or ablation. that is in the proportion of 1,000 compared to the 10,000 of those that cannot have resection or cannot become NED, okay? And then those that may be considered for liver transplantation are in this gray zone. Yes, they are not resectable, but the burden of disease is not too much, or the biology of the tumor is not too aggressive. Like, for example, BRAF mutations are not being accepted for liver transplantation because they are too aggressive, but some other RAS mutations are being accepted. And of course, there's a test of time, etc. So, but liver transplantation would be in the tens of 10,000. Okay, so this is just to give scale to or to give a good context of of the different treatment options. Okay. Now, let's talk about histotripsy. Now that I gave you all the data about what the other options can accomplish in terms of survival, histotripsy, because it's a new method, and we only been doing it for 1 year in United States and in the world. We won't have 5-year survival data. Okay, but how does it work? So first, it's a non-invasive tumor treatment. It does not require surgery. It does not require a needle to be inserted into the liver. It's just ultrasound. Okay, so in that regard, it's very novel. Okay, it could be compared to external radiation therapy, right? But external radiation therapy is a lot more toxic. And what it does is the ultrasound, the shock waves from the ultrasound induces cavitation, that is bubbles that expand and collapse so rapidly that destroys the tissue and the cells, makes them explode. It's like an implosion, okay? And that area that is being destroyed turns into what we call a lysate, or a liquid, okay? A liquid that only has proteins or different components of the cells, but has no viable cells, okay? Now, the important thing is that these cells that are being mechanically disrupted are cells that are usually either cells like liver cells or tumor cells. But some cells that make blood vessels or bile ducts or scaffolding structures of the liver are not being destroyed because they have high collagen. So that allows the liver to regenerate back in that area. Once that lysate or that fluid is being reabsorbed by the lymphatic system of the liver will eventually regenerate in that area. This is a little video that you probably saw, but just to give you an idea how is the setup for histotripsy. We do histotripsy in the interventional radiology suite. Some other centers do it in the operating room. Some other centers do it in an intervention room that is not specific to anything. But we need to have the patient under general anesthesia. That's important to understand. So if patients that have severe heart disease or severe lung disease, some diseases that are not related to the cancer, but that are unsafe for general anesthesia, those patients cannot qualify for it. But we put the patient under general anesthesia, and then we use a special water bath. It has to be put over the abdomen in the region of the liver to be able to transmit the ultrasound waves into the liver. And we use a regular imaging ultrasound that is coupled to it so we can see the lesions, okay? All right, so this is this is how the device looks. This is pretty much how we set it up. And then this is a closer view of what happens inside the liver. Okay, if this is the tumor, these shockwaves start creating these bubbles of implosion and expansion, and with that start destroying the cells, okay, and creates a bigger bubble. It's like a chain reaction, and that bigger bubble start going around. We usually have we have a very focal targeting of the beam, and we move it in like around the size of a golf ball, if you want, until we create that size. And here you can see what happens once you have this fluid or the lysate. The blood vessels are usually preserved, and the lymphatics are usually preserved. So that will allow the liver to regenerate in the coming weeks after the destruction of the tissue. This is like a representation of once the lymphatic system absorbs the tissue, the lysate, the liver tissue can grow back into the area. So let's look at the difference between histotripsy and ablation, because in some regards they are comparable, because histotripsy can be used for about lesions that are 3 centimeters or less in order to treat the entire lesion. Okay. And the difference between ablation and histotripsy is that because ablation is it pretty much hits the area and cooks the tissue, the tumor cells on the liver tissue, the regeneration of the liver is not as much. It takes a long time to get reabsorbed the tissue because it's pretty much, it's not liquid, it's solid, and it's like a burnt tissue. Instead of histotripsy, you can see the defect here that at the beginning is very similar to ablation, but then over time, the liver tissue, the normal liver tissue, starts growing over it until you have a minimal scar there. So this is one aspect of histotripsy. The other one is that there's some evidence that we can preserve blood vessels and bile ducts after doing histotripsy in areas of the liver. And the final one that maybe many of you have heard is what we call the abscopal effect, which is an effect that by treating 1 or 2 lesions and by allowing the liver to reabsorb that lysate with antigens of the tumor, that unmasks for the immune system tumoral antigens and allows the immune system to be more active against other tumors that were not treated. That's a very exciting effect. However, we don't see it too often. We see it in about 20% of the cases, and we still don't have a good way to tell which cases are going to have that effect and which cases are not. It's kind of a hit or miss. But I think it's important to remark that this is another potential benefit, and I think with more data, we may be able to determine which type of tumors or which type of genetic mutations or what type of liver or location or size can really respond with this immunologic synergistic effect. This is another example of what we do prior to liver transplant for other disease, which is hepatocellular cancer. But hepatocellular cancer, is a tumor from liver disease that we transplant. But many times before transplant, we have to do different treatments of the tumor to keep it at bay. And these are treatments, these are very sick patients. And we are being able to do this treatment now. Instead of doing invasive treatments like ablation, we can do histotripsy to reduce the tumors or even knock out that tumor until the patient gets into transplant. Just wanted to remark the abscopal effect is a systemic immune response that is triggered by the tumor destruction, and it can expose the tumor antigens, and that can potentially enhance the immune surveillance. Now, this is observed not very frequently, but it's something that is under investigation, and hopefully we can find a way to make it happen more often. We believe that keeping chemotherapy and immunotherapy while doing histotripsy can really help synergize the effect of histotripsy. This is just to show you how in 1 year only the histotripsy was embraced by many centers in the United States. A total of 28 centers now have it, many here in New York. And this is the number of tumors that were treated in 2024. of course, you can see colorectal cancer is the majority of them, about 260 cases, neuroendocrine tumors, pancreatic cancer, cholangio. These are all metastases in the liver. Cholangiocarcinoma, HCC, which is a primary tumor of the liver that we do transplant for, and other type of tumors. And the specialties that do this can be interventional radiology. In some centers, radiation oncology does it as well, hepatology, or surgery. There are different trials that led to the approval of this technology for treatment of liver tumors. Some initial trials a few years back, but the trial that really led to the FDA approval was this Hope for Liver trial, which is a multi-center trial in US and Europe that was able to demonstrate effective treatment once you target and you can go around the tumor and destroy the tumor and the tissue around. That's the effectiveness. It didn't come back within 30 days, which is not long term, but at least within 30 days. And then that is safe, that there were only a few adverse effects because it's non-invasive. There were minimal cases of serious adverse events that we call like infection, like liver failure or death. In those 44, there were the total of 3 cases only. Now, this is the important study, the Boombox trial. The Boombox trial is a prospective trial where we enroll all the patients that are receiving lithotripsy, and we follow them up for 5 years, okay? And this is why it's so important, because we really need to get the 5-year data to be able to compare to all the other existing tools that we have to treat liver tumors. So we are participating on this study where we actually enrolled 3 patients already, and I think it's important, that if you are receiving lithotripsy, you're very likely going to be enrolled in the Boombox trial, or you may be even enrolled in some other specific trials that are using lithotripsy in different contexts. For example, in the context of certain chemotherapy, certain immunotherapy, or associated to other treatments. I have a clinical case that is a transplant case. Just wanted to highlight that there was a woman that had diagnosis in 2020 and had surgery for the colon in 2021, January, and then had liver metastasis a year later, had surgery in the liver in 2022, where they removed different lesions. They removed 7 lesions, okay? So it was resectable, but in the high risk end, and had ablations, then had chemo later. And then 5 months later, as soon as they stopped the chemo, there were some tumors that came back, they recurred. So had another surgery in January of 23, 1 year later, with resection of 3 lesions and ablation again. And then was followed by chemotherapy again. And so this is a colorectal cancer operated in 2021, liver surgery in 2022, liver surgery in 2023. And every time that they stopped the chemotherapy, the tumors were coming back into the liver. So the patient was sent to us to discuss different options of treatments. Had no mutations that were of concern for us. And then just wanted to show you a little bit of at the time of presentation, the tumors that were active was 1 here, 1 here, 1 here, and another here. 4 liver tumors, and there was an area that was also non-viable of liver. So we did a first intake. We did a PET scan that showed us that the metabolic volume of the tumors were not that big. Okay, metabolic tumor of was 90, which the best survival is 70 or less, but 90 is quite acceptable. And we had, you can see here, 1, 2, 3, 4, 4 tumors, and there was a question about fifth tumor. So in this case, we could say, well, there's enough liver and there are only 4 tumors. Why don't we go back at it and resect it again? Yes, but this is when the concept of biology and resectability can come together with, anytime you stop the chemotherapy after resection, the tumors come back. And this was the 3rd recurrence. So we were a bit skeptical about doing again a resection, and we presented this case at the tumor board. We did the other staging, the chest, the bones, and there was no evidence of disease anywhere else. So we presented this as different treatment options. One was to start the chemotherapy, of course, repeat resection and ablation. We could refer her to another center. We don't do the hepatic arterial infusion pump, but she could go to receive hepatic arterial infusion pump and then resection. The problem here was she already had multiple resections, or we could include her on the transplant pathway. And so we reinitiated the chemotherapy, and then 6 months later, after 3 months later after chemotherapy, she got stable disease. We decided to do a periportal lymphadenectomy to make sure that the lymph nodes around the liver were negative, and these were negative. And then we continue again chemotherapy for another 3 months while we gave Y90 to keep the tumors at bay after stopping the chemotherapy. And we were able to restage again. We didn't see any evidence of disease outside the liver. The disease in the liver was better. There was less tumor burden. Here you can see the PET. This is the lymphadenectomy. Sorry, this is the lymphadenectomy that we did. So after we did a final run of staging, and we found that it was controlled liver disease with those 4 lesions that were smaller, the tumor volume on the PET scan went from 90 to 64 under 70. We considered that she was a good candidate for liver transplantation, and we were able to give a live donor liver transplant from Sun. That was in May, and so far at this point, she has no evidence of disease. So I think this can illustrate all the different therapies that we talk about, except for histotripsy for this case. But we would consider histotripsy in some cases that are going into transplantation, to show you that there's always we always need to find a way to either make someone resectable or someone that can have aggressive treatments like ablation, like a hepatic arterial infusion pump, to see if they can respond and they can become resectable or they can become transplantable. And ultimately prolong the survival more than 50% at 5 years, which is the goal. I'm going to open the floor for questions.
Thank you so much. I've learned a lot. This was great. I think it really, talks to all the different treatments and how they can be used together, and a great, introduction and of histotripsy. And I know we appreciate it. So I'm going to go through some of the questions. We have a question on transplant. Is it always best to have a transplant if one is a candidate for that and not resectable? So I think sort of looking at that pathway.
I think it's worth to have an early consultation. If the diagnosis is unresectable and no evidence of disease outside the liver, I think it's worth to have a consultation. Remember, anytime you go to a transplant center to inquire about transplantation for this, they will put you on a protocol that will require at least 1 year of wait time from the time you get a diagnosis, and maybe 6 months after removing the colon, and having chemo for about a year at the very least to show that you have stable disease. And then we do all this testing to make sure that there's no disease outside the liver. Many centers do this surgery before the transplant to remove the lymph nodes, to make sure that there's no lymph nodes that are positive around the liver. So really it's a process. So if there is any question about eligibility for transplant, I think it's important to go to a transplant center that has a protocol for that and inquire.
We have a question about general anesthesia. So I think it's obvious that transplant and liver resection are going to be done under general anesthesia. But I think as far as histotripsy, Y90, the ablation, SBRT, some of those treatments, does a patient have to be under general anesthesia, or how would you handle that?
Yeah, that's a great question. Any surgical procedure, of course, is under general anesthesia. Ablation, it depends on the center. For percutaneous ablation, some centers do it with sedation only, depending on the location. Some centers prefer to do it with anesthesia because they have a better control on the movements of the patient. With histotripsy, it's the same thing. Histotripsy requires anesthesia because we need to have, when you target the lesion and you treat it, the respiratory movement has to be predictable. Okay, so with anesthesia, we can control the movement of the lungs and how the liver moves, and we can decrease the amplitude of the movement to the minimum to try to stay in the area and not burn, for example, when we're doing histotripsy or ablation, but mostly with histotripsy, we don't want that area to move too much, because maybe then the ultrasound beam can go into the colon or to the stomach or to the duodenum, to areas that are not liver, and can damage those areas. So that's why it requires general anesthesia. Now, if we find a way to do a less invasive treatment, like, with ventilation that doesn't require general anesthesia, that's in discussion. But so far, to my knowledge, none of the centers that do histotripsy are avoiding general anesthesia. Everyone is using general anesthesia so far. For radioembolization, you might not need general anesthesia. That's sedation only. Or radiation, you don't need anything.
Is it logical to pursue partial histotripsy with the intent of downstaging before other therapies such as SBRT or Y90? In other words, is it logical to target one part of a tumor with histotripsy and then use another therapy to finish the areas that were not treated? For example, in cases where Y90 or SBRT would not get all of the tumor alone or would be too risky? Yes.
So that's a very important question. And this highlights the role of multimodal treatments, right? Yes, histotripsy can be done for what we call complete treatment or partial treatment. So if histotripsy can be done, let's say, the liver has 3 tumors, the 3 tumors are under 3 centimeters, and they're in spots that are safe to burn around the tumor, or just do the histotripsy to lysate the tissues. So that would be a complete treatment. Okay, there were 3 lesions. The 3 lesions were completely treated with histotripsy. That's a complete treatment. Okay, now for most of the cases, we do histotripsy in situations that we have more tumor burden, multiple lesions, different sizes. And what we do is we try to do a staged histotripsy, right? We treat 2 or 3 tumors at a time. And sometimes if we cannot, for example, if there's a tumor that is 5 centimeters, we may treat 3 centimeters once and then come back and treat the other 2 centimeters, the remaining 2 centimeters, and to try to clear the entire tumor. Or sometimes we can associate, sometimes we have multiple tumors. Some of them we can target them with histotripsy, but some others may be in a difficult location for histotripsy, either because it's close to the colon, close to the stomach, or high up, are surrounded by lung, and it's hard to get the ultrasound beam to get there. So sometimes we use combined modalities of histotripsy with ablation or histotripsy with radioembolization in order to treat all the tumors that are in the liver.
Thank you. Could you provide your thoughts on getting a hepatic pump with replaced right hepatic artery abnormality?
Yeah. So the arterial anatomy is an issue, and the eligibility of the hepatic arterial infusion pump depends on different variations. But the problem would be when you're trying to inject, you want to inject the catheter of the pump has to be in an artery that goes only to the liver and not anywhere else. So many times when you do this procedure, I don't do this procedure, but at Memorial Sloan Kettering across the street, they do it, and so they are very detailed about the different branches of the arteries where the catheter is, to make sure that that chemotherapy goes only into the liver and doesn't go into the stomach or into the pancreas, into the duodenum. So many times when you have a right replaced hepatic artery, it may be very difficult to control the flow, or can even reflux. Okay, and that could be a contraindication. That's right. So if you were turned down because of having a right replaced hepatic artery, this could be a contraindication. Yes.
For tumors that are under 3 centimeters, is radiation equally as effective as ablation? I think you talked a little bit to that, but I did want to ask that.
Yes. So this is the collision study. The study that I show is a multi-center study in Europe that just came out with the final results. Actually, the study was stopped earlier. So the study was designed as a non-inferiority trial. This is the gold standard was resection for tumors less than 3 centimeters, and they started comparing ablation for those same tumors, same size. And they couldn't see any difference, significant difference. So they recruited 300 patients, 150 and 150 pretty much. And they stopped it early because there was no difference in the outcome. Okay. So this validates ablation as an equal treatment to resection for tumors under 3 centimeters. Of course, the devil is in the details, and that doesn't mean that in your specific case, you should have an ablation and not a resection. That depends on the location of the tumor. Again, sometimes the access with the ablation, sometimes we do it with surgery, but sometimes percutaneously it's not as easy to access every tumor in the liver than with a surgical ablation, or sometimes a resection may make more sense. That depends on the specifics of the case.
Thank you. And this is from a patient that actually had the histotripsy procedure done to 3 lesions in the liver. The patients had 2 CT scans since the histotripsy, and is just wondering, other than comparing the size of tumors of those treated lesions on the CT scans, how would the patient know if histotripsy induced abscopal effect has taken place?
Yeah, it's so far the way to tell is with imaging. This could be MRI or a CT scan that has contrast, and with that, between 2 to 4 weeks after the procedure, you could see the abscopal effect is if you got treated 3 tumors, but there are 3 tumors that were not treated, you should see a rim enhancement in the tumors that were not treated, like there's some activity, inflammatory activity around the tumors. If you do it early, maybe 2 weeks later, and if you do it later, like 4 weeks later, if that already happened, you should see a reduce in the size of the non-treated tumors. The only way to document abscopal effects nowadays is like with imaging, so far.
Can you comment on the HAI pump for patients after resection to help prevent recurrence? So, when a patient would get a pump to help prevent recurrence. I think you did comment some on that, but I just wanted to ask that here.
So the pump has benefits. It's an aggressive therapy. Okay, it's like like 2-stage hepatectomy or even liver transplantation. These are aggressive therapies, and it has benefits, but also has some drawbacks or toxicities. The benefit is if you respond to the pump and you can downstage the tumors to make them resectable, which 50% can respond, good news, you're in a good spot. And if you respond and you get, you can have resection, for example, the chances of recurrence is a lot less after using the hepatic arterial infusion pump. So not only it can reduce the burden of disease and make it resectable, but also it will prolong the amount of prolong the recurrence-free survival. Okay, so that's important. On the other hand, sustained treatment with the pump can lead to liver toxicity, and in some cases can lead to some irreversible liver damage on the bile ducts. It is reported to be 1 to 3%, but when it happens, it's a real deal. So, again, as part of an aggressive treatment that can be very effective, it's always important to discuss the potential risks of having liver injury or having to interrupt the treatment because there's liver toxicity. Not every patient can continue the treatment, and sometimes it has to be interrupted. The management of the pumps requires a multidisciplinary team. It's not only the surgeon, but it's the very specific oncologists that know how to manage the dosing in order to manage the toxicity in the liver and to try to mitigate the potential injuries to the liver.
In your opinion, how many times can you perform resection and targeted therapies on the liver before you would consider that transplant path would be the best path forward?
Yes. Well, the clinical example I showed you was 2 times resected, and the third time that recurred, we decided to do a liver transplant. It depends on the presentation. If someone presents with unresectable disease, but in that gray zone that it's unresectable, but the tumor burden, the size of the tumor is no more than 5 centimeters, there can be multiple tumors. The metabolic volume on the PET scan is not high, it's not more than 90. Okay. Of course, that kind of patient has to be on chemotherapy. So if it is stable on chemotherapy or responding on chemotherapy, and we see that there are like, more than 6, 7 lesions, okay, it could be considered for transplant because we know that resecting 6 or 7 lesions with surgery, the chances of recurrence is very high, right? And the long-term survival, as I showed in one of the curves, of resection chemotherapy of 7 or more lesions, the 5-year survival is about 25%. Okay, so some cases that present like they could be considered for transplant from the get-go based on how they present and the number of lesions and the type of mutations, we would consider transplantation, up front. But clearly resectable cases with low risk for recurrence or a lower risk for recurrence, we would resect first.
Does Weill Cornell have different criteria for transplant than Columbia?
Yes, there's not too different, but Columbia just started doing this. I think that they just listed a patient, so they're trying to use the more recent criteria from the transplant trial. We have our own criteria. Our trial has been around since 2021, and we evaluated 35 patients. We transplanted 5, so we actually are with Columbia we work together. We are kind of under New York Presbyterian. We are 2 different universities or 2 different type of faculty under the same hospital system. So we work on 2 protocols together, and we are actually working on a common protocol based on our experience with transplantation and their experience.
Does the liver regenerate in areas where you receive Y90?
Not so much, no. The areas that were not affected by Y90 will regenerate, but the liver that receive Y90 will not. And depends on the dose too. Okay, the doses of Y90 are very variable. It depends on some mapping studies to make sure there's no dose that shunts into the lungs, or depending on the goal of the Y90, if it is to destroy a specific area of the liver or to give lower Y90 like before transplant to kind of keep the tumor at bay. But lower Y90 is very toxic too. So sometimes if we give the lower Y90 too early before transplant, we may have some liver failure. So I think it's important to understand, at the timing of the transplant. If you have a live donor, it's a lot easier to really have a good timing and be able to schedule the Y90 3 months before transplant, knowing that at that time if the liver has failure, can be rescued with a transplant. When you go into the on the deceased donor wait list and it's more unpredictable when the transplant is going to happen, sometimes we can run into liver decompensation or liver failure from the lower Y90 that was already beaten up by the chemotherapy too, and prior resections, etc.
Is histotripsy an option for patients with the BRAF mutation, and then as well a RAS mutation such as NRAS or KRAS?
Yes, there's no contraindication based on mutations for histotripsy. The limitations on histotripsy are certain size of tumors or certain locations where we may not be able to clean the entire tumor from the liver. But if there's no other therapy available, I think histotripsy is totally indicated. Yeah.
I just want to make sure.
We do histotripsy in patients that we would not be doing any other therapy because they have disease. We know that the liver disease is the one that really dictates survival. So many patients that present to us with liver metastases, but they have lung metastases, bone metastases, and they are generally doing well, and the liver disease is threatening their survival. We do histotripsy on those patients.
Is it possible if you have a tumor right next to the IVC?
With what technique? With
histotripsy. Sorry. Mm-hmm.
Yes. The IVC is a big vessel, same than the hepatic veins. We usually anticoagulate for that, because even if the vessel is preserved, the skeleton of the vessel is preserved, but the endothelium, which is the cellular lining that is very delicate on the blood vessels, that one gets destroyed, but the structure remains. So that gets that endothelial lining gets repopulated very quickly. But to prevent clotting, we give anticoagulation. So for the hepatic veins and the IVC, the vena cava, I think it's safe to do it with anticoagulation. For the portal vein, though, it's a bit trickier, okay? Because the portal vein is a different type of flow, and sometimes we can have despite anticoagulation, we can have disruption we can have clotting on the portal vein, and that's something that I have to be careful. So lesions are very close to the center of the liver, where there's a lot of portal branches. We try to avoid them.
And I apologize if I missed this one. We just have a couple questions left. One is, what is the largest size that can be treated with histotripsy?
In different sessions, you can treat larger lesions. It all depends on the location, and sometimes large lesions, you may be able to access with the ultrasound beam an area of the lesion, but the other area is too high. There's too much lung that doesn't let you deliver energy. But 5-6 centimeter lesion, if there's no other good option to treat it, I would try histotripsy. Now, we should consider, usually for lesions that size, we also consider Y90, because Y90 is very effective at reducing large size lesions if they are not resectable, right?
Let's see. I think all the liver related questions are pretty good. I think we've got some people saying they're going to make an appointment with you. I think you had your email on that prior slide, that last slide. So I just want to make sure that as part of the recording, everyone can see that, everyone in chat. So if you do have questions specific to your case, especially, and you want to seek a consult, this is the email, with follow-up questions. I feel like we got to most everything that we could.
I'm not very reliable with emails. Some days I'm in the operating room all day, and the emails may get buried. I get many patients that send me emails, but I think it's probably better to leave an office number, because at least someone can be more accountable for replying. But yes, I can send the office number, and we have three assistants that usually take all the calls.
Perfect. If you send that to me, I'll make sure that everyone gets it. And I appreciate that. I appreciate all of your time. You've spent an hour and a half with us tonight, late in the evening, and we are so appreciative. I learned a lot. This was great. I know that the patients and families here tonight got a lot out of this, and I just can't thank you enough. So thank you so much. And there's a lot of thank yous in the chat.